Hi, and welcome to your PMP My Pod video podcast. This is the only podiatry podcast that will help you succeed in your final podiatry class while also giving you pointers for success in clinics. I'm your host, Jared Shapiro. Today's topic is trauma. As you can see, I titled this Trauma is Fundamental. So why did I split that up? Well, trauma is fun. It's interesting. It is rewarding. Patients come in bad state and you get to fix them. So that's pretty cool. Of course, is because you might think this is really simple. If it's broken, you fix it. You realign it. You get the two bones to stick together, and you do your best, and that's good. Well, yes, but it's also um, challenging. You'll see there's a lot to know, and it's also mental. You have to really put some thought into this. So you'll see where we go from here. We're going to cover a variety of things today. So let's start with some housekeeping. Okay, the first thing is on the YouTube channel for Pimp My Pod, there's a Q&A session where you can put a comment. So if you have a question about something that we're talking about or reviewing, feel free to put a comment in. I will check this at least several times a week, and I will add the Q&A into the podcast section. And if it's something that's really significant and we need to make sure that it's not covered by something that you can voluntarily watch, then I will also put this into emails and other communications as well. Okay, now some other housekeeping. There is a couple of errors in the recorded lecture that covers gunshot wounds, so soft tissue injuries. As you can see, this kinetic energy equals 1/2 mv2. That's not 2. That should actually be 1/2 mv squared, and that's actually an important difference. So you recall from the discussion on the video that kinetic energy has a lot to do with the severity of an injury. So really, if you look at this, the mass of the object is important, but not quite as much as the velocity of the object. So a large object moving very slowly is going to be less damaging from a bullet standpoint than a small bullet that's going much faster. So the square of the velocity as opposed to just an equal relationship with the velocity. Now, the other slide that was an issue was this next one where it mentions that the exit and the impact they're different. They determine the volume of the wound, and this one too. It's not V impact times 2. It's V impact squared. So again, exactly the same 1/2 mv squared equation, just one where it is now squared. So again, this is an important slide in the sense that how fast it goes in is going to be important, but when it slows down rapidly because it's hitting something like a bone or something like that, it's going to slow down really fast, but it's going to do a huge amount of damage while it's inside. So keep that in mind. Okay, now to have a little bit of fun with this, let's talk about the pick of the week. If I had an experience that I would pick for the week, it has been receiving my second COVID shot. So about 3 weeks ago, I got my first one, and it made me feel not so great for about a day. It was, I could get through it. I had some myalgias and some fatigue, and that was it. But today, this weekend, I received it on Friday, which was about a day and a half ago on the recording of this lecture. And on Friday, I felt okay up until 4 hours after I got it. So I got the shot at 7 a.m. at the start of the day. Around 11 o'clock, I started feeling not so great, myalgias, a little bit of fatigue, and then it just got progressively worse. So I spent yesterday basically in bed, aching and feeling terrible the whole week. So from an experience, that would be it. I am feeling so much better. It just at about 9:30 last night. That's about maybe 30 hours after the actual shot. The illness part of it just turned off. It was like I had broken a fever and I was good after that. So that worked out really well. But more importantly, here's the pick of the week for me. These are actually two books. One is called Learn Better, and the other Make It Stick. And both of these books cover how we learn, and these are really applicable to how you study. And there's actual science and psychology behind how you can study successfully. So these books together to me make up really excellent discussions about the best ways to study. And I know it might be a little late. It's you're almost 2 years into your training, and you're like, okay, great, but um, it's actually still very usable. I mean, I'm way out of school, and I found these both really good. So they cover a variety of issues, but I'm going to boil it down for you here. So the first one was that they talked about effort. So none of this should come easy. Okay, and the problem with passively learning, like listening to something and never do anything with it, is that it just comes easy. Your brain doesn't have to work so hard. The next one that they talk about is called retrieval practice, which is basically quizzing yourself or quizzing somebody else. This has been found to be a much better way to study than something called mass practice, which you might know this as cramming. So, cramming at the last minute just does not work. Retrieval practice works really well. Then there's something called spaced practice, which is um, which is you study the same thing but at multiple different time points. This is the reason why I tell students that they should study a little bit of podiatry maybe every day. 20 to 30 minutes a day, and that's pretty much it. Then you're coming back to it. You're reviewing things repeatedly. You can also do what's called interleaving, where uh, uh, you take, let's say, three subjects, and you study one, you study it for a little bit, you stop, you study the second one, you stop that one after a period of time, you study the third one, and then maybe you come back to the first one. And what that does is it causes you to slightly forget, and then you have to work a little harder in order to remember that, and it causes you to have better long term retention. The next thing that they talked about, which I found very interesting, especially having been sort of taught in the style of, what a learning style is. That idea of I'm a visual learner, I'm a kinesthetic learner, I'm an auditory learner. Those learning styles have not been found to have any scientific validity. So if you think you have a learning style, you don't. What you really have is a preference, and that preference is just something that you enjoy. Now, what does work is when you mix a variety of learning styles together. So you should read, you should watch things visually, you should listen to things auditorily, you should draw pictures. All kinds of things like that will help you learn better. And then finally, you should look for underlying principles that cover the thing you're studying. So for PMP, for podiatry, you're really going to be comparing all the various traumas together and seeing how they're similar and what are they like. And the same thing is going to be true for discussing other kinds of of topics in podiatry. Really looking at the similarities is important. Okay, so that brings you to the question, really, is there a better way to learn? And I think the answer is yes to that. So just to discuss these just slightly more, I wrote an editorial about this in 2019. If you didn't know this already, I've been writing a online editorial for Present e-learning systems called Practice Perfect. I've been doing this for about 16 years. If you want to look at more detail about what I was just talking about, you can read that particular article. It's Practice Perfect number 669. So if you just Google Practice Perfect 669, you will find that, and then you can read this in a little bit more detail than what I just talked about. Okay, let's get on to the cases and kind of talk about some concepts that might be helpful for you in studying for PMP. So we're going to start with this first case. This is a male patient who presented to our office and originally saw one of my partners. He had left big toe pain after he dropped a heavy glass table on his toe. Um, he and his wife are both medical professionals, and so they treated it initially themselves, but it continued to bleed. So he asked for a visit. He had been self-treated with ibuprofen and amoxicillin 3 times a day, and continued to have some pain and bleeding, so decided it needed to be treated. Now, if you take a look at this image, you can see a darkened nail of the hallux. That's a subungual hematoma. And on the proximal nail border, that area just proximal to the nail, is a lacerated area. And that's where the bleeding was coming from. So the first thing I'll mention is it's a little out of order, but amoxicillin by itself is not a proper treatment for anybody with a toenail issue or really with any foot issue because of um, resistance, antibiotic resistance. So it's really more typical to treat with something like amoxicillin clavulanate or augmentin. You think about that from the dog bite standpoint or the human bite or cat bite, they're all really treated very, very much as with the first line therapy is augmentin. Okay, so that gets into the treatment part of this, but it's just worth noting. Uh, so if you take a look at this, from a principle standpoint, let's think first about blood supply. What are the chances that this patient lost the blood supply to his toe? Well, considering that there are 4 small arteries going to the digit, so 2 dorsal and 2 plantar that just follow the interdigital nerves in the same way, the injury is distal. Now we see bleeding. We also see the tip of the toe is pink. So we know that vascularly this patient's intact. So that's one of the first things you're going to try to determine when you're evaluating a patient with an acute trauma. You can see that there's bleeding under the nail, so that's something to keep in mind. What about alignment? Well, the toe looks grossly in anatomical alignment, so we're okay there. Neurologically speaking, if you touch the patient's toe, you use maybe something sharp and see if the patient has sensation, then you know that they're neurologically intact. And then the other thing, if you think about anatomy, so remember, always keep anatomy in mind. It's the absolute fundamental skill or piece of knowledge that you're going to have. So if the laceration went transversely across the digit, what is there that we would have to be concerned about? It's the extensor hallucis longus tendon. So that's the main thing that we're going to have to worry about. The question is, was it cut? So we do an exam and we check and see. Very simply, see if the patient can dorsiflex the digit. And if you gently put your hand on top of the digit to resist it, you will see that the EHL tendon fires, the digit dorsiflexes, and it hasn't been cut in this case. Okay, so we know that the tendon's intact, the neurological and vascular status is intact. Now, do we even need to treat this with antibiotics at all? Like the question you might ask is, well, this doesn't look infected. I mean, it's really not very red, maybe a little bit swollen, not terribly. It doesn't have the clinical signs of an infection. Okay, well, let's keep that in mind for just a minute. Let's look now at the radiographs. Now, what do you see? I see a comminuted, mostly non-displaced fracture of the distal phalanx of the hallux. If you look at those lines, the proximal lines make a mostly transverse appearance. Then you have a longitudinal split that goes right down the middle, and then that splits again at the distal portion, and this creates three pieces. So this is a comminuted, non-displaced fracture. And it's so let's keep in mind the other skill about reading radiographs. Okay, so if I were to ask you, how do you read a radiograph? Or if I was to say to you, interpret the radiograph for me, I might say something like, and there's lots of ways to do this, but I might say something like, I see two views of a skeletally mature, uh, this is a left foot because the radiograph said so, not because I know that this is a left foot in the images, but because the clinical appearance said it, and I'm telling you these are his x-rays. So it doesn't, I'm not sure, I could always have flipped it around. So this is an AP view and a mortise or medial oblique view. So I'm sorry, so a DP and a medial oblique view of the forefoot of a skeletally mature adult. I see the soft tissue around this is mostly intact. There are no foreign bodies. There's no gas. I can see that the joints are intact, and there is a disruption of the cortex of the distal phalanx of the hallux, which is comminuted, non-displaced, with a transverse proximal appearance, longitudinal central, and then distal split longitudinally, creating three pieces. These are extra articular. So that would be your read. What a hint that I will give you is once you see the fracture, stop looking at it. Just look around. Look and see any other fractures. Did I miss anything? Could there be something else that's there? I look at all the cortices and I run my eyes across them. I look at the Liz Frank joints, just at least I can see it on the DP view. I look at other joints. Are the sesamoids intact? Then you will not miss anything. So what I did was go from distal to proximal. Okay, so here's the lateral view. Now you can see the kind of transverse appearance of the proximal part of the fracture, and you can also see that the distal half of the distal phalanx of the hallux is displaced slightly plantarly. Maybe that's a millimeter or two at the most. Now the other thing you might notice is that the hallux is dorsiflexed in this image. The reason for that is that if we got a regular lateral, there would be overlap of the other toes, and so we wouldn't be able to see the hallux at all. So this is an elevated hallux lateral view. Okay, so we've read the radiograph. I'm going to just go back for just a second back to this now that you've seen that. So if this happened just recently, so if it happened, within that first 6 to 8 hours, that was that golden period that was discussed in your prior lecture. In this case, it's a few days later, so I would not start the patient on new antibiotics because it's too late. Now, this is considered an open fracture because you have a laceration with a fracture. So this would be an open fracture. And this actually explains why the patient should receive antibiotics for at least 3 to 5 days, because we want to prevent infection. Now, is it mandatory? No, but think about your Gastillo-Anderson classification. This would be this looks like maybe it's a little more than a centimeter. Let's say it's 2 centimeters. So this would be a type 1 Castillo-Anderson. Now, originally in their work, they did not give these patients antibiotics, and they did fine. But it is typical for us to give antibiotics to open fractures. So take what you will from that. Okay, so let's now move on to a slightly different case where this is a patient of mine that I saw, oh boy, some months back, maybe 6 months ago. And I wanted to highlight a couple of things about the soft tissue envelope and the fracture underlying it. So I'll tell you right now, right from the start, that this patient sustained a Liz Frank injury. So he was actually riding a bicycle. He fell and caught his foot in the stirrup of the bicycle. So he kept moving, and his foot stayed exactly where the back of his foot stayed where it was. So, very typical injury nowadays to have a Liz Frank injury as a result. Now, take a look at this, and you'll see first there is an absence of the normal skin lines on the foot. So he has a lot of edema. That's the first thing. So if we're considering when to treat this patient, either let's just say surgically for now, but if we're thinking about treating him surgically, then we have to consider, is the edema too much for us to do surgery on? And in this case, it was decided to do surgery on him because the edema wasn't so bad. So we didn't see fracture blisters. You'll notice the absence of those. You'll see an area of darker ecchymosis or hyperpigmentation on the sort of lateral view of the foot. On that plantar medial arch area, you can kind of see an area of hemorrhage, but there's no blistering. Now, the other thing that you might notice is that he has a bump on the medial arch, the medial side of his foot, looking at the sort of dorsal view of his foot. Um, there is a medial bump. So that's not good. That's the first thing that told me that this patient had a Liz Frank dislocation. Now let's take a look at these x-rays. Here you go. Take a minute to look at those. And you'll see that this patient has what would be called a homolateral dislocation because the first, second, third, fourth metatarsals all went laterally. So Queno and Kuss, homolateral. You can also, classify this with other ways, which I will let you think about. And if you could tell just how dislocated these are. Now, if I'm looking at at radiographs for a Liz Frank fracture dislocation, I'm first going to look at the AP view, and that will show me where the first and second tarsometatarsal joints are located. And I'm, looking at the medial aspect of the metatarsals and specifically the first and second metatarsals and their associated cuneiforms. And I'm going to look, and that's how you're going to see very subtle injuries. Now, these are non-weight bearing films. They're not stressed. So this guy was unlucky enough to have it so bad that you don't need to stress it to see it. But in some cases, you'll want to actually dorsiflex and evert the foot in order to stress it and cause those metatarsals to move. And that's like a stress dorsiflexion view. So on the dorsal plantar radiograph, the first and second metatarsals are obviously translated laterally. The third metatarsal looks like it's articulating with a cuboid. That is not the right place to be looking, or at least that's not where it's supposed to be. Now, if you look at the medial oblique view, this view is better for us to see the fourth and fifth metatarsals and sometimes the third metatarsal also. And you can see that the fourth metatarsal is laterally translocated in comparison to the cuboid. Okay, so that's not good. That's not where that's supposed to be. It's supposed to line right up on the medial aspect of it, along with the cuboid. And then you can see on the lateral that the first metatarsal and the second metatarsals are dorsiflexed in relation to the cuboid, the medial cuneiform. Okay, so what I could tell you is that Liz Frank fracture dislocations are much easier to fix surgically if you treat them early. And in fact, that's true for just about every fracture you can think of. There are very few fractures that are easier to fix the longer you wait. In fact, I can't think of one off the top of my head. Maybe there's one, but not one that I can think of. Okay, so that looks pretty bad. It's not terrible, but pretty bad. So we've considered the soft tissue envelope. We would have looked at his, palpate his pulses, check to see his sensation. This is not an open fracture. The edema is not so bad. The soft tissue envelope is not so bad. Okay, well, here's his post-op view, and um, so I don't want you to get too lost on the details of this, except for a couple of things that I'll point out. So the first thing is that we repaired the first tarsal metatarsal joint first, and what we did was actually a primary fusion. So we didn't just do an open reduction internal fixation. The reason for that is that the evidence shows from a couple of very important articles that uh, purely ligamentous Lisfranc injuries do better if you do a primary fusion rather than an open reduction internal fixation. So fusing it actually turns out to be more successful. So that's why we decided to do the fusion. Now, I chose to fuse the first and second tarsometatarsal joints, and I'm going to explain why I didn't do the third in just a minute. First, you can see that there's a longitudinal screw down the sort of shaft of the first metatarsal, and then there was a staple that we used as secondary fixation. And you remember, 2 points of fixation is better than one. The screw that's used is fully threaded. So if I'm using a fully threaded screw to compress it, then I am doing what's called lag by technique. Okay, so I underdrill and overdrill, and that causes the screw to compress. Now, if the screw were partially threaded, then I could tell you for sure that it was a lag by design. I would have only underdrilled when I created that hole. Okay, then my little plate there, that's actually a compression staple, and that is done by, if you see the two little sort of squiggly lines, well, the bridge of that staple is made where I can open and widen that. And when I widen it, when I spread the two little arms apart, that will cause the bridge of that staple to shorten and become shorter. That shorter distance is compression. Okay, then you can see that there's a screw running from the second metatarsal to the intermediate cuneiform in an oblique fashion. And that oblique screw, people will call a Lisfranc screw. And what we're doing is we're pulling the second metatarsal to the medial cuneiform. And that could be run either from the medial cuneiform to the second metatarsal, or the second metatarsal to the cuneiform. It's okay. You can go either way. I found this to be easier in this patient to go from the dorsal towards the plantar direction. Just easier to put the screw in that way. And either way, that was okay. That one, now that screw, which you can't tell in this, was just underdrilled, not overdrilled. Okay, so the reason we did that was we had already uh, realigned the second metatarsal, and we were not compressing it down too tight. We were just kind of holding it in its location. And then by doing that, we were also holding the second tarsometatarsal joint, which we had already debrided. So we got a good fusion from that. Okay, now the thing I want you to notice is not as much the fixation as the fact that we never fixated the third tarsal metatarsal joint. But it also reduced entirely. Once we got the primary dislocation taken care of, the third metatarsal slid back along to where it went. And that is called the Vassal principle. So if you reduce the primary fracture or dislocation, then secondary fractures or dislocations will also reduce, and that is due to the attachment of ligaments or ligamentotaxis. So If those ligaments had been really damaged between the second and third tarsal-metatarsal joint, we would not have seen a good correction. So that would tell you that they're no longer connected via ligaments, and the vaso principle wouldn't work. Okay, this fella did just fine afterwards once we got anatomic reduction. So you remember, we're going through principles. So you remember the AO principles. So anatomic reduction, uh, rigid internal fixation, uh, anatomic dissection, and early range of motion. So by putting in this fixation, we were able to allow the patient early range of motion, not early weight bearing. So this patient did not bear weight until I knew that he was fused, but I'm okay with him moving his ankle and his toes. Okay, so we were careful to dissect, not to destroy the tissues, get that solid fixation in there, and then hold that. Okay, so let's talk about a similar kind of case. Now we're going to kind of move ahead to ankle fractures. And it's not really the ankle fracture I want you to focus on. It's really about the principles. And the same principles that are involved with this early material that we're talking about is also going to be true for ankle fractures. So good principles. Okay, so this is a patient that one of my residents sent me from the Kaiser location that they are rotating at, and it was just thank you to the attendings there for allowing me to use this case. So this is a patient who uh, suffered a medial ankle laceration. So that's a 7 centimeter laceration to the medial side of the tibia, and on the right side of the image is the foot, and on the left side of the image is the leg. So this went down to the periosteum, and there were concerns for vascular embarrassment to the foot, right? So remember, now think about that same method of figuring out all the components of the patient. The physical exam was done. The patient was determined to be stable from a general standpoint, and then we start looking at soft tissue envelope, neurovascular structures, pain. Is it pain out of proportion? Does this person have compartment syndrome? Yes, you can have a laceration and have compartment syndrome. Um, we might classify our Castillo-Anderson classification. In this case, this was considered a 3A because I'm sorry, make that a 3B because the periosteum was stripped, but this turned out to be that the vascular status was intact. Amazingly, this patient luckily had um, flow from the other arteries into the rest of the foot. So it's called retrograde flow. And this patient did not have to have vascular surgery come in and try to fix that. So here are the fractures. This is what the patient had. Now, don't worry about all these fractures. Don't worry about classifying it. None of that is important at this moment. Okay, we're going to cover ankle fractures later. But you can see that there's a medial malleolar fracture, there's a lateral malleolar fracture, there is a lateral dislocation of the ankle, right? So if you think about trying to fix this and the stability of the fractures, you can, maybe these are mildly stable fractures once it gets reduced. Because they are mostly transverse. So remember, transverse was the kind of most stable type of fracture pattern. You know that the problem with this is that it's intra-articular, it's poorly aligned, so that's not good. Now you'll also notice that there are these white kind of ribbings or lines around the leg, and that is, those are the borders of a splint. So this patient was seen by another institution where they had reduced the fracture, uh, at least tried to. They did something, I'm not sure what, but they tried to reduce the fracture and then they splinted it that way. Then they produced so this was then their post reduction. So they got it reduced. Okay, that's better. Things are closer. They're aligned. Not great. If you look on the lateral radiograph, you can see that the talus is posterior to the tibia. You see that gapping in the front? Well, that's not a congruent joint. So this patient still has a posterior dislocation of the ankle. Okay, so this was the first repair of the patient. I'll just mention there a couple of things. So there are a couple of pins or K wires in the lateral malleolus. You remember that from your fixation lectures that a K wire is one method and it does not provide compression, but it does hold things. And then there's a plate which runs over the medial malleolus. That's actually called a hook plate because you can see that the more distal side of that is bent. So they took it's called a 1/3 tubular plate, very commonly used on the fibula. They bent the ends and then they bent the plate so that it would conform to the shape of the fibula. And they put screws to hold it. And you can see a screw that goes from the fibula to the tibia. That's called the syndesmotic screw. Don't even worry about that screw at this moment. Okay, so the fibula and the syndesmotic screw look pretty good. The ankle joint is now in better alignment. Things look about normal, except you can see that on the medial side, the medial malleolus is not fixated. And nobody knows why. So the attending doctors that I spoke to about this patient have no idea why they did not fix the medial malleolus. Um, Probably because of that open laceration, and they were concerned about it. So remember, the worry with open fractures is that if you put hardware into an area that's dirty, then you'll push infection down to the bone and increase the risk of osteomyelitis. Now, if you catch this early enough and it's clean, you flush it, you have all of your principles taken care of, then yes, you can put hardware in that and then primarily close it, as long as you've taken care of it in enough time that it is clean and safe. So the problem with not fixating this is that we're violating the AO principles, right? Remember, rigid internal fixation was one of the four principles. And without that rigid internal fixation, you can see that things will wiggle and move, and that is not stable. That would still need to be fixed. Now, they could have been intending to come back and fix it at a later date, maybe a few days later after the patient had been on some antibiotics. But either way, in a case like this where the patient had presented very early, it is safe as long as the wound is clean. So the repair for the second surgery in this patient is as you can see. So everything on the fibula and the syndesmotic screw were normal, were the same. They left it, and then they went in and they percutaneously repaired the medial malleolus. So they did not go through the prior laceration. They used what are called cannulated screws. You might remember that from your lecture, where they can put a wire through the skin and into the bone, reduce the bone and hold it, and then they put these screws across. And you can see that there are two screws. One screw is providing compression, and the other screw, which also provides compression, is preventing rotation. So the principles of screws are being maintained. The fracture is well aligned, and you'll notice that the screws that are used are partially threaded. So only about, I don't know, half to 3/4 or 2/3 of the screw is threaded. And this is a screw that is lag by design. Okay, so here are your final views on this. You can kind of take a look. And in this case, now if you think about your AO principles, they've all been satisfied. Okay, we haven't violated any neurovascular structures. The anatomic dissection was appropriate. The fixation is good. The joint is really nicely aligned. This patient will be able to undergo early range of motion, not early weight bearing, but early range of motion. And some people will even weight bear something like this early because it is so stable. Now, that one is a sort of individual choice. I don't generally weight bear my ankle fractions until about 6 weeks. And that also depends on a lot of other issues. How overweight the patient is. Do they have any comorbidities? Did they come into this with osteoporosis or osteopenia? Do they smoke? Are there other issues of compliance that I'm worried about with the patient? So all of those will go into that decision. Okay, let's wrap this up with some final conclusions. Um, so first, let's do a couple of kind of quiz questions to help you, and these are sort of hints for the future. So, which of the following fractures is the least stable? We have our original fracture that I showed you from the hallux. That was the transverse but comminuted kind of fracture. Then there's B, which is an oblique fracture with a little sort of what's called a butterfly fracture, where you see where it bent. So this oblique fracture, the fifth metatarsal, that's been displaced. And then the third is a highly comminuted displaced fracture of a hallux, distal phalanx. So which of the fractures is the least stable? If you want to think about this, hit pause. Okay, so C is the answer because this one is highly comminuted and displaced. Okay, so the transverse fracture here is the most stable. An oblique fracture is much less stable. It has the ability to slide. And a comminuted fracture is the absolute least stable in this case because it is just going to roll all over the place. It's going to move. There's no stability at all. Okay, so let's look at that fracture again from the ankle. Which of the terms correctly describes the medial malleolar screws? So I already mentioned this one to you. Do you remember? The answer here was compression, and these were lag by design, and these were meant to compress the fracture together. Now, they can't be lag by technique because the screws are partially threaded. You would never over drill a screw that is partially threaded, so it wouldn't be lag by technique. These are not buttress screws because, well, frankly, there's no such thing as a buttress screw. Um, Run out and land are just two anatomical parts of a screw. You'll remember the run out is the spot where the non threaded part meets the threads, and that is the weakest part of a screw. And the land is where the head of the screw meets the shaft of the screw, and that is made there to allow a little bit of extra compression of the screw head against the bone. Okay, so it's a compression screw. Now, hint, hint, huge giant hint here. Um, I've mentioned several different topics between these two questions, so consider these as definitely fair game for things like tests and quiz questions. Okay, here's our final thought. The thought process, I think, is the most important part of being a doctor and being a podiatrist, being a surgeon, being a medical doctor, any of these. It's the thought process that really matters. Now, anatomy is your fundamental, and your basic knowledge of what you're doing is good, but you have to be able to think through the process. Okay, what we've just basically talked about over this last 40 minutes or so is a structured approach that looks at what happened with the patient, what's their medical history, what does their foot look like, the commonalities between them, the neurovascularly intact or not, is it open, what happens. You have to be able to think through these cases and then come up with a treatment plan. If you have a reasonable thought process and you come up with a good diagnosis, you understand the mechanical issues involved with this, you will do great. Okay, so that's it for today. If you have any questions, please feel free to add them at the Q&A session, send me an email, and I'll see you at the next Pimp My Pod.